Our second presentation is by Professor Eric Larson. Professor Larson is the Vice President for Research Group Health and Executive Director of the Group Health Research Institute. A graduate of Harvard Medical School, he trained in internal medicine at Beth Israel Hospital in Boston, completed Robert Wood Johnson Clinical Scholars and Master in Public Health program at the University of Washington, and then served as Chief Resident of the University Hospital in Seattle. He served as Medical Director of the University of Washington Medical Center and Associate Dean for Clinical Affairs from 1989 till 2002. His research spans a range of general medicine topics and has focused on aging and dementia, including a long-running study of aging and cognitive changes set in Group Health Cooperative, the University of Washington, Group Health Alzheimer Disease Patient Registry, Adult Changes in Thought Study. He has served as President of the Society of General Internal Medicine, Chair of the Office of the Technology Assessment, Department of Health and Human Services Advisory Panel on Alzheimer's Disease and Related Disorders, and was Chair of the Board of Regents from 2004 to 2005 of the American College of Physicians. He is an elected member of the National Academy of Sciences Institute of Medicine. And Professor Larson will talk about prospects for prevention of dementia in our increasing aging society. Good news on the horizon. Thank you, Professor.
Well, good morning. It's a pleasure to be here, and I thank the organizing committee and the program committee for inviting me. What I would like to speak about today is a topic that I've been thinking about for many years, and I'm going to take the point of view of what is the news about prevention. Is it good news or not? And my conclusion is that there are many reasons for good news. Before we and this was not me, but the world talked about life expectancy as being finite, and that there was some, as we got older and older, we would eventually reach a stage where everybody would be dead. We now know that that's not true, that there is no actual limit to life expectancy that we've yet been able to determine. And we also know that senescence, or the type of life that we're talking about in this conference, is actually being postponed, and it's widespread around the world. So what is the news in this new context? To me, the news headlines are shown on this slide, and again, I'm having trouble reading my slides also, so I'll read them here. Widespread aging is occurring in both developed and the developing world, and there's a dramatic increase in the number of people with Alzheimer's disease and related dementias. This may seem to be an economic and social problem, but in fact, I think one can look at it as a better way for people to contribute to society for longer. Widespread variations exist in aging. As a clinician, we know those variations are challenging to us because of the range of problems our patients can present. But variation is actually the key to prevention and optimization. I think that we'd all agree that primary prevention trials for Alzheimer's disease and dementias have been disappointing, but in fact there are now 3 and maybe more studies that show that things are actually getting better, and we may have already seen a delayed onset of dementia in many societies. The question of AD, or multi-infarct dementia, was the one that I dealt with when I was an early scientist and clinician. I think that today we need to think about this not as a strict dichotomy, but because the brain ages in a complex way as a convergent syndrome of neurodegenerative processes. While no treatment has been proved effective at reducing or removing plaques and tangles, multiple risk factors are now available. And finally, the burden of aging is great for our societies. And I do think, and this was emphasized in the early discussions of this meeting, we may already have begun to relieve the burden of aging, and we can do even better. So what about the postponement of mortality? This slide, I think, is information that many of you are very familiar with, but just in a country like Sweden in 1860, there were 3 people who lived to be 100 years. In 2008, there were 750, and the projections are that for those people born in 2007, there will be 50 to 60,000 who will live to be 100. So that's well into the next century. And what we see is more people reaching these milestones of 85, 90, and 95. This is all driven by the fact that people are living longer after they pass the age of 65, 75, 85, and so forth. And Vopel, who's probably done some of the best work in this area, has said that two scourges of old age, which is what we're talking about, are cognitive impairment due to Alzheimer's disease and other sensory deprivations. Here are a couple of slides which I think you can see showing what's called the biodemographic trends. And what you see on this slide is the fact that as in 3 countries, Sweden, the US, and Japan, as we've gotten closer to where we are today, the number of years that the age at which a person lives 5 years and 10 years has gotten progressively later in life. So you can see that some of these ages at which people are living 10 years are coming up to 75 and older. And this has all occurred in the last half of the previous century. What this means is that Alzheimer's disease is becoming extremely common. The incidence of this disease, as defined by the dementia syndrome, is that it begins to really become far more prevalent after the age of 80, 85, and beyond. So what we're looking at is a log scale, not a arithmetic scale here, showing how rapidly this condition appears as an incidence. These are 7 studies and one of our own. This is what the prevalence looks like in a Japanese-American population in my city of Seattle. And you can see that by the time people reach 90 and 95 and above, these numbers are more common than not, so that people who live to these ages in this cohort, when they reached 90 and 95, were more likely to have Alzheimer's disease than to not have Alzheimer's disease. What this translates into is a prevalence curve that shows this dramatic uptick in the late 80s, and that's the age group that, of course, is growing the fastest worldwide, those people above 85, 90, and 95. So what we're seeing is this large population of persons with Alzheimer's disease and related disorders. When I started in this field, we started to see people when they were mostly in their late 70s. Now we're mostly seeing people in a community-based sample above the age of 85. And the duration of symptoms has gone from maybe 3 to 5 years before we saw them to now just a year or 2. And so people are coming in much earlier. And as Professor Du Bois has said, we're making a different way of diagnosing people. What this says to me is that there are a couple of trends here. First is there's a dramatic increase in the incidence because there's a dramatic increase in the people who are at the highest risk for Alzheimer's disease. We're also seeing that what's happening is mortality is postponed to later and later in life. And what I'm saying is that never in human history have we had the opportunity to study so many people above the age of 85, 90, and 95. And I predict that we will learn things that we've never learned before. A little bit like Leeuwenhoek when he found the microscope and looked under the microscope and said, I'm seeing something that nobody has seen before. We will have that happen to us as researchers and people interested in aging. What this means, though, worldwide is that there's a dramatic increase in the population of people who are having dementia, and this is shown by this slide from a paper in The Lancet. And these different colors simply represent different continents and parts of the world. And you can see that as these populations grow and become more prosperous and live later into the lifespan, we get these dramatic increases in numbers. Now, everybody in this room, I'm sure, says, I wish things were better. I wish we had a better way of preventing this disease. And for many years, I think we looked for a magic bullet to treat the disease. And this slide simply paints a picture of the fact that most of the drugs that we thought were going to be helpful when I started working in this area have simply not been helpful, and they've mostly been abandoned, although there's still a great deal of interest. On the other hand, if you look at existing data on the rates of dementia, I would argue that we've already begun to see a decline in the rate and risk of dementia. The first study that looked at this was by Manton, published in 2005, and he looked at a U.S. survey and saw that between 1982 and 1999, there was a decrease in the prevalence of moderate to severe dementia in the population from 5.7 to 2.9%. Then in 2008, a colleague and I, Ken Langa, published a paper in the Alzheimer's Disease Journal using the study called the Health and Retirement Study, in which we showed that those people with cognitive impairment went from 12.2% in a survey in 1993 to 8.7% in a survey in 2002, and that those people who became impaired had a shorter life expectancy after they became impaired, a so-called reduction in compression of cognitive morbidity. Then just a few months ago, from the Rotterdam study, the group there showed that the incidence of dementia had declined from 1990 to 2005, as did the amount of atrophy on the MR scans in that study. And they associated this with better education and control of vascular risk in the population in this study. So what do we have here? I've called this a convergence of neuropathologic processes in late life. We try to distinguish just Alzheimer's disease from other causes, but I think that in Skog's paper in 1993, he showed that in people in Sweden who had dementia at the age of 85, there was a strong prevalence of people who had vascular dementia at a time when we were trying to say, is it vascular or is it Alzheimer's? And we studied that in a few years later in 1999, and of all the people we saw in our research with Alzheimer's disease, clinically, neuropathologically, the diagnosis was confirmed, but more than half of them had some other process that probably contributed to their dementia. So the general trend, I think, is to realize that in late life, there's far more importance to mixed dementias than we thought 20 or 30 years ago. The unique study that made this point better than I think any so far is a study of a large accumulation of community-based populations in the United States. Our study, the Honolulu study, the Nunn study, and the Oregon brain study. And what we looked at in this study was people who died without dementia and then looked at their brains. And what we found was that people who had no clinical dementia had a high frequency of neuropathologic changes. And of those that had the autopsies, 10% had enough brain neuropathologic changes to be called demented based on the normal criteria that a neuropathologist would use to say a person was demented. This slide is hard to see, but what it shows is that in each of the 4 studies, as the age increases, the number of people who had neuropathologic changes in their brain that we consider abnormal, degenerative changes, becomes higher and higher. And yet these people died without evidence that they were clinically demented. So what would I say as a summary? First of all, probably most importantly, mortality is being postponed and populations are older. Equally important is the notion that senescence is not inevitable. And in fact, I think that's what this meeting is all about, is working on the concept of how does one postpone senescence. There are several neurodegenerative processes that are going on, probably not just Alzheimer's disease, but the interesting thing about this is the amount of variation. And variation is the key to prevention and doing something about a phenomenon that may be seen as inevitable. These can be the clues to prevention. So if that's the case, what is the evidence for the level of potentially modifiable risk factors? Since no treatment has been proved to be effective, what might those be? And the modifiable risk factors were identified in a paper in Lancet in 2011. This group said there are 7 of them, and I've listed them here. 3 are cardiovascular, 1 is obesity, another is depression, the 6th is physical activity, and the 7th is low education. So if an epidemiologist looks at these numbers and says, well, what part of the population is exposed to this risk factor and what amount could be reduced if this risk factor were eliminated? And this is their analysis for the United States of the prevalence of physical inactivity, 33%. This, if it were changed to eliminate, would reduce the risk of dementia theoretically by 21%. And as you walk down this slide, you can see that each one of these factors has a certain prevalence, and that leads to a population attributable risk, or PAR, and together they add up to over 50% of risk reduction through this analysis. If you take a look at this on a worldwide level, what you see is what's seen on this slide, and it's basically the same as what you saw on the previous slide, except that low education worldwide is a much greater risk factor in terms of its prevalence in the worldwide societies. So if you take these numbers and say, well, what if we could change this by 10% or 25%, which is well within the range of what public health has done for other conditions. This is what you come up with in terms of the number of Alzheimer's disease cases which you would be able to potentially prevent worldwide. The red column is if you reduce it by 25%. The blue column is if you reduce it by 10%. So substantial numbers of people who you'd think would have been demented might be no longer demented, but might live their life and die of something before they develop dementia. So the implications of this is that up to half of the AD cases may be attributable to modifiable risk factors, and I acknowledge this is theoretical. Public health interventions to increase or improve education and physical activity, decrease smoking and depression could have a dramatic effect on the amount of Alzheimer's disease in the world and in each of our separate countries. Obviously, we need intervention studies to begin to look at this. Let me give you a few examples of how potent these risk factors might be. The first is a study that we did many years ago now, looking at exercise in our adult changes in thought study. And what we looked at was the number of people who were clearly not MCI, but scored above the 25th percentile in our screening test. And we compared them to the people who developed Alzheimer's disease and other forms of dementia. And the rates are shown on this slide. 13 per thousand who exercise 3 or more times per week versus nearly 20 per thousand who exercise less than 3 times per week. And the risk reduction was lower at the lower, was greatest at the lower performance levels. Probably more important, though, are randomized trials. And this, I think, is a very important study that came out a few years ago from Australia, the Lautenschlager study. And the thing that I think is important about this study, which it was a walking study, basically, and it showed that a year and a half after the walking intervention group was studied and then compared to a control group, they had a 0.69 point difference in the ADAS-Cog. If you look at this difference, that's greater than the difference than most cholinesterase inhibitors have in published research, according to the Cochrane Review. An even more exciting study, I think, and this relates to the work that Bruno Dubois cited earlier, is a study from the US in which people looked at the hippocampus in late adulthood, knowing that this part of the brain decreases in size as we age normally, and that this is associated with impaired memory and often is considered the start of Alzheimer's disease, and I happen to agree with that theory, by the way. So they looked at a randomized trial of exercise and showed that the hippocampal volume increased by 2% in the group that was exercised compared to the group that didn't exercise, where there actually was a decrease. This was associated with a increase in brain-derived neurotrophic factor, and very strong evidence in I think a very rigorous study of an anatomic basis for one of our risk factors, exercise, being affected by essentially a preventive medicine intervention. These are the other vascular risk factors. I've simply taken them from the chapter in Up to Date, and I won't go over them in detail, but hypercholesterolemia as a risk factor probably in midlife. in our work anyway, seems to be associated with a reduced risk. Hypertension, there probably is a U-shaped or a J-shaped relationship, whereas you really want to control blood pressure in midlife and late life, and be careful as we control it in late life. Diabetes, smoking, atrial fibrillation, all of which are associated with risk factors that are great enough to have public health importance. So what are some of the conclusions that I would draw here in Vienna in the 21st century? I'll read them from my slides. There's been a general improvement in midlife health, and especially in the control of vascular risk factors. This has been worldwide, in the developed world at least. And combined with effective treatment and maintenance of physical activity, healthy diets, they have the great potential to further promote cognitively healthier, long lives. The conclusions that I cite today are based on descriptive research and time trend type analyses. Clinical trials are needed, but I would argue that this is going to be very difficult to do, the real definitive clinical trial. The strongest evidence to date is based on habitual exercise, and I think that will continue to accrue. I can't imagine that's going to change in my lifetime. Interesting areas to speculate. A paper on mental retirement showing that in European countries, the age of social retirement is associated with cognitive function. A very important paper as we think about the fact that there's so many more people living to old age who could actually work longer, especially if they wanted to work longer. The other one is that we have an obesity epidemic, and actually that could cause a reversal of almost all the trends that I have talked about today. More people are living to old age, and absent a war or a major catastrophe, I think that will continue. There will be a lot of very old people who are at high risk for dementia. Those of you who work in the field, you do not need to worry about job security. There's going to be a lot of work for all of us. And because I don't think we'll ever completely prevent this condition. It seems to be that some of it will happen, but there's a very good chance that many people will live longer and live throughout their life without dementia if we continue, because we know that exceptional longevity is possible in the very, very old population. Social policies, as you've discussed in this meeting, I think are extremely important and will make a huge difference in the years to come. Final slides are really that the senescence has been postponed by about 10 years in my years in medicine. The other thing is that the baby boom generation, I'm not sure about in Europe, but in the United States for sure, every time the baby boom generation has entered an epoch, things have changed. And I would predict that the baby boom generation will change how we experience aging as a society. A global approach, as this meeting has emphasized, is important, and plans to deal with the baby boomers, I think, could be extremely important. Prevention trials will help a lot, but I do think many of the changes that we'll see will simply be changes that we see because of the march of time. I think reducing the late life burden of dementia is already been done, and I would predict that we can do even better as we go forward. Widespread prevention trials will be needed, and thus I think we will end the talk with a good news about prevention of dementia. Thank you.